I thought when I saw the question I was asked to comment on, immediately of doing what I normally do in these cases, which is reframe the question. So, so I thought about, for example, how can research and care be more integrated? And using the history of cancer registries, which were initially research-based, as an example. But then I thought, Julie will probably do such a fantastic job of illustrating how research and care needs to be integrated, so I shouldn't comment on that. Then I thought maybe I should talk about how to run an academic medical health center. Should it be a single or double-headed monster and so on. It would be an evening-filling topic, but probably not very interesting. Or I thought maybe we should talk about don't waste a good crisis. Something needs to happen. We know for the next few years something needs to happen. Change needs to happen. Maybe this is the time where this can happen, and then go through a couple of ideas of what that would be. And then I thought of the revolutionary idea to just focus on the question which has been asked. It's, not so much what can healthcare do to help research, but what can research do to help healthcare. And the one guiding thought I would like to share is that this country has a globally acknowledged and admired capability in computer science, creation of the internet, in data science and mathematics, and in medical science. And what probably is required is to bring these together in a completely different way and to redefine what translational means, to redefine education, to redefine medical education, to redefine computer science, to redefine data science. And let me just try to explain why I'm saying that. The traditional model of research to care is to come up with something great, showing research excellence, won't dwell on the details here, and publish it and hope for adoption, which is a 20-year journey from idea to something to happen. However, the world is changing forever, or has changed forever. We are seeing three very, very significant factors. The first one is the world has created more data in the last 2 years than in the entire history before, and this is going to continue. The amount of data created over the next decade and the growth of that data through sensors, through Fitbits, through all sorts of things will vastly, vastly grow. The second one, we have unbelievable further increases in computational power. Over the last 10 years, 1,000-fold increase. Basically, this means computing is free. Computing before was very expensive. That's why we couldn't really look at all this data. Now we have much, much, much more data, and we can basically analyze it for free. The third big trend is the most important one, which is the ability to link that data and make sense of it. We believe there are many scenarios. Some people think it's 2030, some people think it's 2050. We are seeing in our lifetime the point at which machine intelligence will match human intelligence. Now, if you think about the implication of that for anything, it's huge, of course. And it takes 14 years to make a doctor. Today is 2000, a specialist doctor. Today is 2016. So by the time people who today start medical school will graduate, human and machine intelligence will match. Have we fully understood, actually, are we actually preparing for that? Are we actually thinking about that? And I would say this is here today. There are lots and lots of very strongly data-enabled professions and businesses which make use of machine learning today. If you look, for example, at Formula One, nothing in Formula One happens without data, without linking lots and lots of data from your own team and from a competitor team. One of the more interesting stories is in Formula One there is not only one race, but two. The second race, the invisible race, is the development of the car throughout the season. And if you, top left, if you essentially look at all projects, a Formula One season is 3,000 projects. These projects can be mapped in two simple dimensions, which is, on the one side, how complicated are these? How interconnected are these projects? And the second one is, how well is the team communicating? How do you measure that? Well, you measure people's email, people's calendar behavior, etc., etc. What you don't want is people who work on simple projects to communicate a lot, and people who work on complicated projects, you want to communicate them a lot, but you also don't want over-communication, under-communication. If you get the winner in Formula One, the loser is on the top, the winner is on the bottom. If you manage, essentially, how do they do that? They kill projects of teams which don't work well together. That's basically what they do. Another example, pharmaceuticals. This was a very, very highly performing clinical research organization. They ingested data from 350 trials, lots and lots of patients, lots of countries, the HR data, the email, what is the clinical team saying to each other, and so on. One interesting finding. A clinical operations team normally has about 30 roles. One role is the project leader, one role is the toxicologist, and so on. They found that the collaboration behavior between 3 out of these 30 roles explains a year in trial length, like loss or gain. A year in trial length is very, very valuable. How can you measure the collaboration between these 3? Look into their email, look into their calendars. Which means we can use data today, we can link data, very hardcore performance data, such as how long does a trial take, which patient is recruited, which patient is late, to very soft data, such as what is Sally saying to Jane in the email when they talk to each other. Are they actually collaborative? Are they likely quite hostile, and so on? And what can you then do? Think about the variation we are seeing in healthcare. Think about the variability of hospitals' performance. Think about what we just heard over a 10-year decade-long improvement performance program where variation has been reduced. The amount of data we can now use, link, make sense of, in order to improve care is phenomenally increasing. And what can research do to do that? Well, we have very, very strong computer and data science capabilities in this country. The 3 things research can help on is, number 1, to get the data, number 2, to link these data, build data lakes, which is, and the third one is to train the people who are actually able to make all of this happen, which are probably the world's most scarce resource. I'm recommending to all my kids, whatever they do in university time, to also learn coding. So number 1 is getting data. We talked before about chips. Every second US hospital bed has already chips. Patients have chips in them, sinks, soap spenders, anything which moves equipment. It is probably a single printer has embedded maybe 80 to 90 sensors. So you can know a lot about what is happening in each of your printers. You can know a lot about what is going on in each of your instruments in the hospital. The first thing is to get the data out. And for that, you need to tag them or chip them. Second thing is to build data lakes. One of the opportunities the cloud environments are now providing is to create secure, linkable data lakes, where essentially every single data point gets a tag, an address, a unique address. And with that, you can basically, you don't need to know what you want to analyze. You can forever analyze all that data and link it however you want. So you can, on an ongoing basis, permanently fish in the data lake and learn and change your entire model away from big plans and so on to much more iterative learning by essentially creating data lakes. Lots of people in this country work on this. They're probably the only, for example, 300 people at Big Data Institute at Oxford, etc. Not enough of those people work in healthcare. So the first thing is to get these people into healthcare and help to begin building data lakes. So Third thing, which is really something for universities to think about, we basically, not everybody can learn everything. We need people who can actually connect these things. So we have data scientists, mathematicians, we have who basically code in Python or R or whatever. You have the computer scientists, the pipes, who make sure that the data flow. And of course we have lots of clinical disciplines, including medicine. We need to train doctors to learn to code, or to at least understand what people who code do. We need to have mathematicians who now understand a bit of medicine, et cetera, in order to make all this happen. This has pretty profound implications for what medical schools, computer engineering schools, et cetera, would do. But if we would like to be leading on this, we could, A, hopefully finally link all this NHS data which is out there in a quite easy way and cheap way, and B, develop all these care models we want. We want consumers to have access to their data, we want doctors to have lifelong records, etc. All these things are doable if we get this done. Thank you very much.